Hi, this is Dr. Acker, and this is the lecture for Module 2, Malignant Disorders of the White Blood Cells. When looking at the malignant disorders of white blood cells, there are two types. There are myeloid neoplasms and lymphoid neoplasms. During this lecture, we're not going to discuss all of them. However, we are going to discuss in the myeloid neoplasm section the acute myeloid leukemia, or AML. And under lymphoid neoplasms, we're going to discuss the acute lymphoblastic leukemia, or lymphoma, ALL, Hodgkin's disease, and non-Hodgkin's disease. When looking at the acute leukemias, the purpose of this lecture is going to be to cover ALL and AML. We're going to touch on the signs and symptoms, laboratory findings, differential diagnosis, and treatment of these two types of leukemias. When looking at acute leukemias and the signs and symptoms, this is the patient that's going to come to your clinic and report that they've been ill for only a few days or weeks. The patient may be experiencing bleeding, usually due to thrombocytopenia, occurring in the skin and sometimes mucosal surfaces. This may occur with gingival bleeding, epistasis, or menorrhagia. Infections due to neutropenia are caused because the neutrophil count falls below 500. If the neutrophils fall below 100, infection usually occurs within days. The common pathogens that occur are gram-negative bacteria such as E. coli, Klebsiella, or a fungus such as Candida or yeast. Presenting symptoms of your patient may include cellulitis, pneumonia, or perirectal infections are the most common ones. The patient is at risk for death within days, if not hours, if not treated promptly with the correct antibiotic. Another presentation by this patient may include hyperleukocytosis. With this disease, circulation is impaired and circulating blasts increase to greater than 100,000, causing headaches, confusions, and oftentimes dyspnea. Mortality with this condition can reach up to 40%. When looking at the physical exam of this patient, they may come in and appear pale, have purpura or petechiae, gum hypertrophy, rectal fissures, and some variable enlargement of the liver, spleen, and lymph nodes depending on the stage of their leukemia. Bone tenderness may be present, particularly in the sternum, tibia, and the fibula. When looking at laboratory findings, the hallmark of leukemia is the combination of pancytopenia with circulating blast. Pancytopenia is the deficiency of all types of blood cells, including the white, red, and platelets, and this is due to the bone marrow stem cells not functioning correctly. An easy way to think about this is the bone marrow either works correctly, or it doesn't make enough blood cells, or it's full of other stuff preventing the proper function, as is seen in this case. This can cause problems with oxygenation, and you may see low oxygen saturations on your patients if you do an O2 sat, and it causes problems with the immune system. As we talked about with the last lecture, almost every disease process that we see will affect the immune system in some way. Acute leukemia is diagnosed by having greater than 20% blast in the bone marrow. A typical suspicion may be caused by the patient's CBC, and then it's also then confirmed with a bone marrow biopsy. Now, differential diagnosis, this is a really important concept that everyone needs to grasp if they're going to be providers in the future. Differential diagnosis is used by providers, and it's typically used to narrow down the vast possibilities of multiple diagnoses for their patients. I would really encourage you guys to start thinking about these diseases, and in doing so, make a list of your top 3 possibilities. So, for example, if you have a patient that comes into the clinic with a complaint of right ear pain, an easy differential diagnosis for this patient would be otitis media, otitis externa, or possibly allergic rhinitis. From this list, then, you would do a physical exam, or you might order tests to help narrow down the diagnosis. So, when looking at the differential diagnosis for acute leukemias, you may want to include left-shifted bone marrow recovering from a previous toxic injury. When looking at AML, you need to distinguish it from CML. and ALL from CLL. Lymphomas and hairy cell leukemias also need to be distinguished from each other. It may also be confused with some form of atypical mononucleosis or even a pertussis. So we'll discuss differential diagnosis throughout the semester as we're looking at all the different diseases that we're going to talk about. Now, during this course, I will bring up possible treatments for these diseases. This will not be tested on. It's just for your information to kind of close that loop for you as you're looking at your patient as a whole. So the treatment for acute leukemias would typically be chemotherapy if caught early enough. When looking specifically at acute lymphoblastic leukemia, or ALL, there are a few things that you just might want to remember. This is a very rapidly progressive neoplasm that's caused by immature lymphoblasts that overtake the bone marrow and often can infiltrate other organs. Many causes of leukemia are out there, but more commonly it is due to the replacement of normal bone marrow elements by malignant cells. Other causes could be organ infiltration, radiation, or chemotherapy products that then cause secondary ALL. ALL is leukemia that's known primarily as a disease for children. It accounts for 80% of the acute leukemias in childhood, with the peak incidence of all ALL between the ages of 3 and 7 years. It does actually account for 20% of acute leukemias in adults, but again, this is primarily a disease that affects children. Now, when looking at acute myeloid leukemia, or AML, this is primarily the adult disease, with the median age of onset being approximately 60 years of age. AML is a rapidly progressive neoplasm that is derived from the hematopoietic precursors or myeloid stem cell dysfunction. Genetic events occurring early in the stem cell maturation process can lead to leukemia, but it's been shown that there's a 5 to 10 year lag time to the development of the disease. This often causes secondary AML. Now, as we keep moving on, we look at lymphomas. This would include Hodgkin's and non-Hodgkin's lymphomas. Malignant lymphomas are derived from the immune system, from which results from a neoplastic proliferation of the B or T lymphocytes. Tumors may be seen in all areas of the body, but are most commonly found in the lymph nodes. The two types of lymphomas that we're going to discuss, and the two types that actually only occur, are Hodgkin's versus non-Hodgkin's lymphoma. So as we're looking at the two different types, Hodgkin's lymphoma is composed of a mixture of all different types of cells with a unique biology. The defining factor for Hodgkin's is that it has the presence of a Reed-Sternberg giant B cell seen when you do a Gram stain. All other lymphomas are considered non-Hodgkin lymphomas. They are primarily B or T celled in origin. They can be caused by congenital or iatrogenic immunosuppression, such as in diseases that we're talking about this week, such as AIDS or even an organ transplant. Non-Hodgkin's lymphoma can be slow or rapidly growing lymphoma. A little hint for you. Please review the table 11-5, the clinical differences in Hodgkin's disease versus non-Hodgkin's lymphomas. That's on page 230 in your text, as this will be covered on the quiz and on the final. So hint, hint, make sure you guys look at that. So let's delve a little deeper into non-Hodgkin lymphoma. Non-Hodgkin lymphoma, again, we're going to talk about the signs and symptoms, laboratory findings, differential diagnosis, and treatments. So when looking at this, the signs and symptoms, this is the patient that will present with a painless lymphadenopathy that may be isolated or even widespread. It can occur both centrally and peripherally. They may also present with fever, night sweats, weight loss greater than 10% of the prior body weight. When looking at the lab findings, it's pretty interesting that with non-Hodgkin lymphoma, the circulating lymphoma cells are not seen in the blood, and the peripheral blood appears normal, even though this is caused by these cancer cells overtaking the bone marrow. The diagnosis is made by a tissue biopsy, and I just want to let you guys know, when you do tissue biopsies, it's for this type of disease, it is much more accurate to do a node biopsy than to simply do a needle aspiration biopsy. So let's talk about differential diagnosis. If you think about how this patient presents, I'm sure that as nurses, you guys can come up with at least one really easy differential diagnosis. What comes to my mind immediately when I look at these symptoms is tuberculosis. As nurses, we've all screened patients with these symptoms. Fever, night sweats, weight loss. It would not be uncommon for them to have lymphadenopathy because of their infection. So, as discussed in the previous slide, the need to differentiate between the different types of non-Hodgkin lymphomas is paramount to the appropriate treatment. So really the differential diagnosis would really just be being able to decide which type of malignant cell this is. Is it Hodgkin's, non-Hodgkin's, and so forth. So the treatment for this is widespread. There are really two thoughts on a non-Hodgkin's lymphoma. By the time these lymphomas are discovered, they are so widely spread that they may not even be considered curable, so then no treatment is available at that time. If it is caught early, then the treatment that's usually given is in the form of chemotherapy and/or radiation. So as we move forward to a Hodgkin's lymphoma, and looking at, again, the signs and symptoms, laboratory findings, differential diagnosis, and treatment, this is the patient that may present with, again, a painless mass, most commonly found in the neck. They may or may not have fever, weight loss, or night sweats. Here's a little interesting tidbit. A very unusual symptom of a Hodgkin lymphoma is that pain is involved with the lymph node that it's affected after drinking alcohol. So it's kind of curious. If you have a patient that comes in and says, I was drinking last night and I got this lymph node and it really aches, that's just kind of a little odd symptom, but that is definitely indicative of a Hodgkin's lymphoma. Laboratory findings. This would be the same as what you see in a non-Hodgkin's, but it does have the presence of the Reed-Sternberg cell that's derived from the B lymphocyte when you do a gram stain. Diagnosis for a Hodgkin's lymphoma is again confirmed by biopsy. Differential diagnosis would again be the same as a non-Hodgkin lymphoma, and the treatment for this disease would typically be chemotherapy. So this was just a really quick overview of these types of diseases. It's more than what the book was giving you, and I just not only want you to know the pathophysiology of it, I want you to be able to relate it to the diseases that you may see in practice. These would typically not be diseases that an FNP would treat, but this would be the patient that presents to your clinic and you start to work up and then realize, oh, look, they have this, and you refer them to hematology for further treatment. So as we discussed, some of the malignancies of the white blood cell, these are not all inclusive of all the malignancies seen. So again, please review your module overview. Be sure to complete all your reading assignments and videos, and don't forget to go back to the table. I'm trying to find my notes here to tell you which table that is again. Give me just 1 second. Table 11-5 on page 230, Clinical Differences in Hodgkin's Disease and Non-Hodgkin's Lymphoma. Feel free to email me or call me with any questions you may have on this, and have a great week.